John's giving me the nod of approval.
So it means you can go, mate. It means you can go.
So, John, Brady, thanks for being here. To start off with, do you want to give us a introduction of who you are and what you do?
Yeah, great. Thanks, Jack and John, for having me. My name's Brady Green. I'm a physiotherapist. I work full-time in elite sport as a physio at the Essendon Football Club. My background's initially that I completed my undergraduate in physiotherapy, followed by a master's in exercise science, specialising in strength and conditioning through Edith Cowan University. And then from there, I began to undertake research and research-related activities through Lateral University, which culminated in me completing my PhD and involved publications in the areas of calf and hamstring muscle strain injuries. Yeah, that's a bit of a synopsis of me.
Sounds easy.
Easy, yeah.
I don't know about that.
So you keep a pretty quiet lifestyle, man.
Yeah, sounds like it.
What got you interested in doing your PhD? Why did you want to go down that path?
Yeah, I was always interested in research itself and reading research and trying to answer clinical questions in a rigorous way. And then I guess understanding what you're reading and hopefully being able to apply that to your practice to improve outcomes.
Yeah. I think that's going to be a topic of discussion.
Yeah, I think it's a big
today.
thing. Yeah.
Because I was going to actually ask you, you say answering clinical questions in a rigorous way. What do you actually mean by that?
I think there's always that first step where you're trying to gather information and you want to ensure that that information is reputable and I guess you can rely on it. And moving from that first step of gathering information, then if you have a good foundation, you're in a better position to take action or implement clinical decisions.
This is something you and I have talked about a fair bit before. I speak to John about a lot too when we think about the process of applying research to clinical practice. And we've spoken before about the difference between applied research and looking at your basic research. And it seems to me that there's a lot of emphasis now on always looking at applied research, often to the neglect of understanding some of those basic sciences and what principles can come from that. What are your thoughts and perspectives on that?
I think there's a place for both areas of research. And as physios, when we're trying to make a decision or work out what to do, if we can be gathering information from lots of different sources, we have a better overall perspective and we have improved ability to create a good action plan for that specific scenario. So I guess my perspective is that as physios, we should be looking into applied research and basic sciences or sort of your more pure sciences. Understanding that as well, with some of the pure true sciences, we're not going to have the understanding as, say, a mechanical engineer or a tissue scientist, for example, but we certainly should have an appreciation for the principles and the key concepts and information that can improve our decision making. Yeah,
I think that's something that we all three share in similar, where we've all done our masters in exercise science, and I think we were all in a similar situation where we felt that that particular component of exercise science was lacking in our undergraduate studies. And for me, one of the things I took away from that is not so much about all the applied research that's done looking at the particular outcomes you see with, say, certain resistance training protocols, but understanding particular principles that you take away from the application of different types of exercise. Like one of the biggest ones I always find that's so useful to remember is, well, one, that we are able to adapt, but also two, that adaptation only occurs when you reach a certain threshold. And this is something that I often find becomes a problem when we look at, say, protocols, and this would be something that I think would be useful to talk to you more about as we go into this, of is that protocol appropriate for the person that you're dealing with, for that individual? And so this is something that, well, again, I'd like to hear your perspective of what kind of framework do you use when you think about looking at research findings and seeing the average of the outcomes from looking at that group of participants, and how do you apply that to the individual? Do you have any particular guidelines or framework that you use to think about how you think of tailoring the program to the individual?
Yeah, really great question, and I'm glad we're talking about this. In that, I strongly believe that it's important to have an understanding of frameworks and data as a foundation, and particularly as we're developing as clinicians throughout our career and improving our knowledge of particular areas. You need to have some level of foundation there. That goes without saying. And aside from having that knowledge, the important thing is that if you have a foundation of conceptual information, that gives you a really strong platform to then diverge or use your clinical nous to adapt to a specific scenario or a specific case that presents itself to you. An example being, if we're rehabbing a soft tissue injury, say a hamstring strain, the thing that's often thrown out is it's a 3-week injury, whatever it is, that's fine. But then from that basis, what other contextual factors are relevant? What other things going on in that person's training history or their life is relevant to how you're going to manage them through their rehab? So a few points there, but I think that's my overall philosophy in that it's important to have an appreciation of protocols or frameworks and things, but then we need to take the next step and take into account context, intrinsic factors, extrinsic factors, because that then will permit us to have a far better management plan.
Has that developed organically for you, or has it been a combination of this research stuff as well as clinical practice, or is it something that you've taken, that we always, I think, steal liberally from other professions, or whether it be within the medical field or whether it be from outside of that? Have you gathered that information and start to build that framework from those other areas, or has it been something that you feel like it's just organically developed through your experiences? And if it has come from those experiences, which ones have you seen be useful? Research, clinical, combination, extra study in other areas?
Yeah, I think over time it's just developed with important experiences in each of those areas. And I think underpinning that, being across the literature in both quantitative and qualitative areas, and seeing the use of both. Some of the key sort of clinical experiences for me have been sort of graduating my involvement in sport.
Yeah, he's being modest, but he was a very good footballer, for those who don't know. So, has that been a big influence on the way that you view a lot of these injury problems? When you're in this professional setting, I'm sure you understand, you probably have had some of these injuries in the similar context, and you know what's around that. Turning up to play, but having to get, it's like that mentality of, we've got to get back on the ground. I want to get back to play.
Yeah.
These guys are obviously getting paid probably a lot more money than you were getting paid to play, but there was still a similar thing. I know you played, say, country footy, and if you didn't play, you didn't get paid. So there is still some of that contextual stuff.
Absolutely.
That you understand. How has that kind of influenced the way in which you work with the athletes themselves?
So there's no disputing there's constraints and pressures there that are unavoidable. We're in a performance environment where it's going to be, at times, in the best interest of the team to get people out there as soon as possible. And that potentially challenges some of what we think with reference to pathology.
When you take that on as a clinician, how do you balance that out? Obviously, I've always found this the most difficult thing, and I don't know, both of you can answer this, but for you, you're employed obviously by the football club. Your job is to try and maximize the outcomes for the team and for the performance of the team. But as a clinician, I always feel like my responsibility is to the individual, the patient, the client, whoever it is. Like, how have you found balancing that? Because I feel like often in those more professional settings, you often get put in the middle, and it's a very hard balancing act.
Yeah, great. Yeah, excellent point. And like ultimately, first and foremost, the athlete's health outcomes are your responsibility.
Yeah.
And you have to do right by them.
You're graded on that, correct?
In what sense?
Like professionally, when they're looking and reviewing your performance in your job, are they like looking at that kind of stuff, or is it more about the performance outcomes?
Yeah, health outcomes are part of our KPIs. Things like injury incidence, injury burden or number of matches missed through injury, and then breaking that down to injury types and how that's trending over a number of seasons. That's sort of important KPI-related data for us. But the point I was making is that, first and foremost, as a clinician and as a multidisciplinary medical services team, the athlete's health is our number one priority. But invariably, depending on pathology severity or the type of pathology that you're dealing with, there can be room to move either way in terms of being more aggressive or being more conservative.
How much does the players' input have on that?
Yeah, so this is where I'm getting to.
Yeah.
So then if things are perhaps trending better than expected, or there are contextual factors, for example, it's the grand final or something, or it's an important player in a particular position for the team's strategy and likelihood of success, then it becomes very much a team conversation around, okay, what is best for everyone managing this issue.
Is the player in on that conversation?
Yeah, so it has to be, when I say team, it's all stakeholders. It's coaches, it's athlete, it's medical, and it's performance, e.g. strength and conditioning coaches and sports scientists.
For those who aren't in those environments, are there significant disagreements at time where people are like, I don't really agree with that position? And obviously, you know that you're working together. It's a safe space to give your opinion. But I've always thought about this of like, where does it land when
people disagree? Yeah. So that's where we really value alignment. And people have to have the opportunity to achieve alignment. So we set time aside for key meetings and key conversations with relevant stakeholders that people can work through the issue. Everyone can have their voice heard and have their say, which is really important because then at the end of that conversation, everyone is aligned on the same page. This is the plan. This is how we're moving forwards. And that's also a strategy to avoid any sort of side conversations that might then happen after the fact if people feel as though their voice hasn't been heard.
Does that also raise some conflict? Like, do you find that generally with the team you're working with, there's good agreement, or there's sometimes where you have to just sometimes have to bite your tongue and say, oh, look, we're going in this direction. I'm not sure if I completely agree with that, but you sort of follow the consensus?
I think everyone feels as though they can be open and honest, and that's the main thing. So, I don't think there'd be any team members that would feel as though something's completely against their wishes. In that, if you followed through a really open process, and if we define that process, that starts at baseline. So someone's been injured, there's diagnostics that occur, there's likely been imaging undertaken as well, and there's expectations from baseline that then as the process progresses, there's opportunity for refinement of prognosis and rehab. And so already there's been organically some changes and modifications made based on what's been seen in the first few days or week. And even at this stage, it's becoming evident to everybody, all stakeholders, how things are tracking, whether it's tracking as expected, slower than expected, or quicker. So even at this early time point, if everyone's had the opportunity to observe that, when it comes to have more, higher level conversations, it shouldn't really be any surprise where things are headed.
Actually, interested to ask you, John, because those of you who don't know, John, apart from working as a physiotherapist, is also a sprint coach and works with national and international level athletes. And you essentially manage all domains of your athletes when it comes to like coaching, rehabilitation. Maybe that sort of fits your personality, or do you actually think
Control
that,
freak.
or do you think there's actually, would you get benefit, do you think, of having more people involved in the decision-making process?
Yes and no. Like, obviously, you know that I reach out to you often to, you know, go through those decisions. I think it's interesting because I sometimes move, you know, across a spectrum with this. I think often, and like as you were talking, Brady, I started to think about like, okay, there's a lot of communication going on here, and they're probably, I don't know whether you guys get training on like how you have team communication and it's actually working, because it's to me, I always find it a really difficult process when you're bringing people in, and I think it's different for you guys where you're there every day and you see everything that happens. I would say that I'm extremely probably difficult to work with unless the person's willing to be in our space, in the context, and be involved day in, day out. If they're not, I don't want to have anything to do with them. You know, and like, I'm sure that I annoy the shit out of them, but like, I have this issue with the VIS. I want their help, but the way that it's set up, which is not to do with any of the staff, because a lot of the staff are actually exceptionally good operators, more so than me in lots of areas. But they don't actually have the resourcing to be in the space day in, day out. And when you're not there in the space day in, day out, you're not having the communication with the athletes, you're not seeing what's going on, it's really hard to actually be able to make an informed decision or put forward communication that's not, it's not that it's wrong, it's just that it's not fully informed.
Yeah, and that's the thing I see with your athletes. Like, you obviously have quite a close connection with them, but that actually allows you to understand all those contextual factors about that individual that are really important in the decision-making process. Because it's actually not just about their injury, so to speak.
Well, there's so much, like, there's so many different things going on. You know, you find out, oh, they broke up with their girlfriend, and this is what's causing this, and their behavior's changing. Like, you know, recently I've been talking with the psychologists through the VS a lot, and I'm trying to, interestingly, they probably find it weird at times, but I'm trying to give them context and background to what I'm seeing in different environments and different parts of their life. And they're like, oh, that's making sense why they're saying these kind of things to me. Because, you know, the good thing is a number of my athletes are seeing this psychologist, even though not all of them are in the VIS. So it's giving me more opportunity to work with this person. And she's an amazing practitioner. I'm really enjoying that process because I'm learning a lot too. But it is interesting because, like, I'll put forward something and she'll say, oh, that's not necessarily how it was conveyed to me.
What makes you also realize too, and we've had these conversations before, of how individuals respond to certain situations.
Yeah.
Whether that's a positive or a negative situation, whether they've had success or they've had failure, because that can obviously determine the trajectory that they head on moving forward.
Yeah.
And this is really important to emphasize. In that at the beginning of our conversation, we chatted a bit about protocols and frameworks versus what we do in the real world. And data certainly won't tell you what's going on in someone's life. Data won't tell you someone's loading response to a particular session, and how we see those sorts of things manifest clinically that then drive our decision making.
Especially like when they come into a session that it may be the same session they've done before, but these external contextual things have changed. Like if you get an athlete come into a session where they have just broken up with their partner and they're in a completely different state, we know that physiologically that has a different outcome compared to when they come in and everything's going really well and they're excited about the session and having fun. So I think that's super interesting. Do you find, because it's always going to be the case, especially in a big place like a football club, personalities are going to vary, and obviously I'm sure there's some players that you're closely with, and there's probably players that are closer with other people on the medical team. Do you find that sometimes you end up having to be conduits of conversation and communication because you can maybe communicate at a more professional level, but you almost have to be that in between? Like I was saying, like with the psych, I'm sometimes being the in-between communicator.
Yeah, and that's where you guys were it was quite obvious earlier. You mentioned it seems like you've had training or processes put in place for communication, and that's where we do have very structured lines of communication and how that works.
Do they literally sit you down at the start and be like, "This is how we want to communicate," or is it like learned by osmosis?
No, it's a little bit learned by osmosis, but then it's also we do have specific communication pathways that just simplifies the whole process. Yeah. And for example, if you just take the passage of that information from clinicians, say, to the head coach, the head coach doesn't need 6 different staff members saying little bits and pieces and everything. They just need a streamlined, what's the word for it? Just a streamlined snapshot of how the person's going and their availability from one voice.
Yep. Yeah, that makes sense.
I was going to ask a question before, like talking about these themes of thinking about group averages versus individual protocol versus, the more nuanced, tailored approach. And my perspective is we've kind of got this challenge within sports medicine, high performance, where probably reflective of human behavior. We typically like protocols. We like to be able to follow a nice linear process of this is where you start and this is where you end.
This is the 3-week hamstring, as you said.
yeah. And again, we've had these conversations many times between us. And I've always found it quite interesting to observe you, Brady, because I actually think you do quite a good job of communicating this, where you have your research perspective, where you're being very rigorous and systematic with the process of how you do the research. And there's a process of how you have to present those findings. Though I've noticed a couple of times I've seen you present, you often will present a framework. This is a framework that we need to look at. And we need to be thinking about the specific requirements of that sport and what that individual needs. We need to be thinking about and we can talk about the tissue capacities when we think about force, velocity characteristics, movement capacity, biomechanical requirements, and then identifying, where do the deficits lie within that individual and how do we then tailor the rehabilitation process to that person? Do you, well, how's the best way to put this? I feel that even though I align with that, John aligns with that, do you think there's still this disconnect where we're looking for, a lot of people are still looking for that protocol-driven process? And if so, why do you think that is?
Yeah, I think there's a safety element to having a protocol. And there's perhaps a natural point of view that if you have a protocol, it is safer and there is less risk associated with a poor outcome. But unfortunately, as we've discussed in the real world, it can often be the opposite. If we're too dogmatic and we stick to a protocol, despite what we're hearing about the athlete's life, despite what we're seeing with their clinical presentation and their responses to loading, if we're too dogmatic and just stick really rigidly to that protocol, that's a recipe for a poor outcome.
Yeah, and this brings me back to the point I made or asked before. Going back to thinking about learning basic principles of basic science versus applied research. And I know if I can just only speak for myself personally, but I know following finishing my undergraduate studies, I didn't feel like I had the foundations of knowledge, particularly around applying exercise interventions. And that's what led me to do my postgraduate studies. When I had that, I felt much more confident going, right, here are some key things that we need to follow in order to see the changes in someone's individual's physical capacity. And then also understanding that unless we identify the particular domains that they need to enhance within their physical capacities, you're going to see that compromise in what their outcome is and whether it's optimal. So it's something that, for me personally, I'd be interested to actually hear your thoughts of, I spend a lot of time reading basic research to continue to enhance my knowledge in that field and understand principles that guide my clinical experience. It's actually probably a good question to ask. Do you read a lot of basic science research still, theory stuff, or do you read a lot more applied research? Like, where do you find you fit in that spectrum?
Yeah, I think a balance is healthy, and I reflect on outcomes that have perhaps been less than ideal, and mistakes that we've made, and often the answers to why that's occurred. It might be some element related to anatomy or pathophysiology or biomechanics. You won't also always necessarily find the answer in an RCT on a single outcome in a finite cohort, for example. So I think, balance is a key component there. And one thing I wanted to mention too is that I think part of the process that I've followed in my research during my PhD was such that, initially the study designs were quantitative analyses of clinical data, and that took us through our first 2 to 3 projects, which was a great undertaking to go through. But invariably, in completing those projects, it was really clear to us that there are certain answers that we won't find in the data. And there were really significant knowledge gaps in the area of calf strain injuries that first we had to identify those knowledge gaps, and then we had to establish some areas that perhaps future research can focus in on. And then that led to us completely changing direction and undertaking a qualitative study, because we recognised that was the only way for us to gather more information that we needed.
You mentioned qualitative stuff earlier, and I was going to prompt you, but you brought it back, so it's perfect.
It's like you read our mind.
Yeah. Typically, people, I think, are more attracted to quantitative research, and I think you've already mentioned the safety and maybe more certainty around what the numbers mean, and maybe that's history and the tradition of that being more available. You went down this path of the qualitative, study, and Jack and I, in preparation for this, spoke about the fact that, like, we find that so much more interesting, so much more useful. As you said, it brings forward these knowledge gaps and potentially even opens the opportunity to close that gap between research and clinical practice. When you made that adjustment, one, was it difficult to say, okay, we need to actually explore this, and two, maybe give us some understanding of where you thought, okay, this is really important that we do this.
I was actually, and just to add to that, I'd actually be interested to hear about your own experiences doing it. Not so much. We can talk a bit about the behind the scenes stuff, because I know you've told me a little bit before.
I don't think it was that much fun doing transcriptions for days on end.
But actually more about being able to pick the brains of a lot of experts.
Yeah, I'm sure that would have been fun at some level.
Well,
absolutely. And
maybe not so fun at other levels.
As you know, John.
For those of you who don't know, John actually was.
Mine was all beaked out because it was just swearing.
That may not have been such a pleasant experience, actually,
for Brady.
But outside of John, was it a useful experience?
So, in an overall sense, it was, I consider, one of the most foremost development experiences that I've ever undertaken.
It's fun talking to people about something you're interested in,
100%,
especially when they're knowledgeable.
Yeah, and while the topic and the subject matter was all related to calf injuries, underlying that, you're getting an understanding for how these, extensively experienced clinicians think, process problems, and the way they go about their day-to-day practice, which for me was an outstanding experience.
Probably a little bit different to the process of the rigorous process of how you do research, within the research setting, so to speak.
Absolutely.
Yeah, like if you had just done the quantitative studies, that formative experience as a clinician would not have been there, clearly.
Yeah, absolutely.
Well, because most of your papers, one, you did the hamstring one and the calf on the systematic reviews, so tipping a lot of time spending behind the computer.
On your own, exactly. And while that gives you an appreciation for the evidence base as a whole, it doesn't necessarily enhance your ability to think critically, problem solve, and be a better clinician. there were a few questions that both of you guys mentioned. Maybe we'll go back to those.
Well, yeah, look, my question was obviously around the actual experience of being able to talk to clinicians.
Yeah.
Because, well, look,
I'm sure there's probably some funny stories too, of things that the experience itself, and interesting things that you picked up that I'm sure you probably use some of them now, and they came from that experience.
But even too, like the kind of language and how they describe their process, because, as a clinician, the process of how you think is obviously very different to as a researcher. Like I often, like as a clinician, you're trying to think about optimizing outcomes. You don't really care how you get there. You're just thinking about what do I need to do, and you don't really care about how controlled the environment situation is, because you might be throwing multiple things at once to make sure that you can get the best outcome possible. It's obviously very different from the research perspective, where you're criticized based on how controlled the environment is. And I think that actually can have issues too about how we think about problem solving, because although having that structure of, say a randomized control trial or some level of control is useful to be able to determine that causal relationship, I don't think it's actually reflective of what we do in the real world, because we're not really that interested
in terms of causality. Just because we're detecting an association with an outcome, there's the underlying assumption that it is a causal relationship, which, as we know, that's not necessarily the case.
It's even as something as simple as how the relationship you have with the person providing that intervention. Like even in a research setting, I often think of this when they'll go to clinics and say, do you want to be involved in this RCT? Here's the protocol we have to use. And obviously, you would expect that a lot of the clinicians working in those clinics would follow that process, but they're still maintaining a relationship with that patient. Like they actually still, and depending on how good you are forming relationships, that's going to have a big impact on whether they actually believe in what you're doing. But even the kind of language that you use, that will influence their perceptions of their problem. So. Yeah, look, I mean, that's, again, something that I think that's a challenge within the field of finding that balance of, should we be thinking about, well, actually, it'd be interesting to hear your thoughts of how do you find that balance, or do we need to be thinking more about how we integrate clinicians and researchers' perspectives in the messages that we give to the audience, give to clinicians?
I think there's definitely scope to involve clinicians in identifying knowledge gaps. So that's probably one point. And then I think it's really important to disseminate research as it emerges in an effective way, so that clinicians can get an appreciation for it. And I think that better places clinicians on an implementation level, because we always assume as well that implementation is done, without issue. And, a classic example, I think, is around some of the implementation of injury prevention programs in elite sport. And, there's some really good data for injury prevention programs in soccer, for example, the FIFA 11 Plus. But clearly there are challenges with implementing that in different sports, athletes with different training histories and injury histories, sub-elite versus elite programs, the actual structure of a training day and a schedule that doesn't always fit with how the research was undertaken. So
it comes back to that issue of like context. And whether it's actually at a group or an individual level, because like you said, the elite athlete, the environment that, say, you're working in, where you have essentially full-time contact with a lot of available resources at your disposal, and most likely quite effective development going into that athlete already, versus, the teenager playing footy on the weekend who has a training history of 0 years essentially, or close to it. it's that messaging again.
Yeah.
Like, how do we actually get that message across of, here's what we found, here's how we need to think about applying this in the real world. Yeah, it's just something that I often think about, and think about how do we make sure we maximize the communication of these messages that are often given by researchers to the actual real world.
Were there any, like, that makes me think of, were there any, when you were doing that analysis, that qualitative analysis, were there any things that you came across that actually surprised you that you didn't expect to come from the clinicians, that allowed you to identify some of these gaps of like, oh, actually, clinically, these people are seeing things that we're not necessarily have seen before in the literature?
Yeah, so the point you're raising there is the premise for why we undertook the study, or one of them. I remember very distinctly, I was at an AFL Physio Association PD, and one of the topics was calf injuries, and we had Craig Purdom and Phil Glasgow
Experienced clinicians, yeah.
and, you know, I was there with one of my supervisors, Tanya Pizzari, and while in those presentations from Purdom and Glasgow, there was data and research presented, it was also very clinical. And Tanya and I left that conference understanding our knowledge gaps, just based on these clinical experiences and the applications and the level of understanding that Craig and Phil exhibited. Demonstrated
what
to
areas
us.
were they talking about that at the time? You were like, okay, we're not
quite there
we're not
yet.
quite there with where we're at.
A lot of it had to do with the rehab process, and the so structuring out how you're loading basically a healing calf muscle after a strain event, and some of the important elements to how you do that with different loading modalities, be it your strength work, your strength power work, your actual power work, your plyos and ballistic stuff that you do on the field, and the decision making around return to run, and then after they recommence running, how you actually progress them to get them back to the point that they're performing at an elite level. Performing as soon as they return to play, and B, not getting a subsequent injury elsewhere, and not straining their calf again or their hamstring or whatever it is.
And I know that Jack and I have been talking about this concept a lot of like, when you design your rehabilitation program, you almost have to very strongly plan around it's a very periodized kind of plan when it comes to not only the factors relating to that specific tissue, as you said, like the calf, but are they actually not going to have another injury because we've just zoned in so heavily on the calf, and you've got to actually look at all of these other physical capacities. I feel like, the more senior clinicians intuitively probably understand that periodization process. And I think as a younger clinician, it was like so foreign. Of like, wait, I actually have to think about, what other physical preparation stuff they need, what other, whether it's, aerobic conditioning, what kind of, anaerobic work that they need to be doing, what kind of, we've spoken recently about flexibility, like what range of motion things do they need to be maintaining,
Absolutely.
what other strength capacities, and for you guys too, I think a strange one is when you're used to getting, physical contact day in, day out, what happens when you don't do that for 6 weeks?
Yeah, exactly.
And what effect does that have on lots of different areas?
Well, and I was going to add to that, because it's something I thought of before with your experience of playing footy or AFL at a quite high level. I know we've had this conversation before of how much can you actually replicate what they need within that controlled environment, i.e., gym training, or even on the field versus a few players versus actually what they need in that open, uncontrolled environment. How has your own experiences influenced that? How do you actually perceive that?
Yeah, it is difficult to replicate certain stresses that they'll be exposed to, and that's unavoidable. And we just have to build out their rehab process with the end goal in mind, what we're preparing them for, and have as many incremental steps along the way to ensure that we're having a graduated exposure to some of those stresses, so that it's not all or nothing once they return, or that boom or bust type approach. And If you haven't done that graduated exposure, once they return, you're really hoping that nothing goes wrong versus having a greater level of confidence. But I wanted to get back to part of what John was saying about essentially identifying the different areas or impairments that an athlete might have, and ensuring that you're covering off on those impairments to ensure that they're not at a greater risk of a recurrence or a subsequent injury. And that's certainly something that we undertake in our practice when somebody gets injured. We kind of do a once over, I guess, clinically.
Yeah, well, it's funny you say that because we in some of the one of the other podcasts that we recorded, we spoke with an AFL player, and we were just talking AFLW player, and we were talking about the fact that injuries present opportunities for growth, and often it's in other areas.
Absolutely.
As a team, are you guys discussing that? Like, you're saying, okay, this is our chance to go and fix that other physical, not ailment, but like development problem.
Yeah, absolutely.
We know that we were going to wait till preseason to touch that, but actually we've got 8 weeks now because they've done X injury. Do you go and start working on some of those things?
Absolutely. From immediately, if possible, as soon as the rehab block commences. If you can, you need to get on that. Otherwise, the impairment or the issue will be there. And we talk about that openly with the athlete. And we set expectations with them that, okay, when you are exiting, we would like you to be at the point where this issue is gone, or you are at this level of capacity in this area.
I've been thinking about this concept a lot, which is that I think a lot of particularly soft tissue injuries are a presentation of lack of overall, say, system capability or output, right, rather than isolated tissue. So, as an example, we've been doing a lot of assessment here, looking at, say, people's power output in general and like a much more, broad exercise, jump task, their squatting movements, all those kind of things. And it's never a surprise to us that the recurrent calf, the recurrent hamstring, the recurrent soft tissue injury seems to be in these people who can't develop, high numbers of power at an overall system level, right? Are there... For you, as someone who actually has extensive understanding of an isolated muscle tissue injury, where do you place that? Or am I completely off track?
No, absolutely. It's something that I implement in my clinical practice, trying to identify these. One of my colleagues refers to them as energy leaks.
And that's how we sort of look at it.
Energy leak theory. And if we're talking about calf injuries, we really ensure that we're assessing what's happening at the hip in terms of your abduction and extension, peak torque for a start. And we all know, based on our understanding of biomechanics, that load absorption and propulsion occurs throughout the kinetic chain. And if we have the person who strained their calf during the stance phase of running 5 times, clearly we need to try and optimize what we're getting from elsewhere to ensure that we're not overloading the system distally.
It's that issue of that reductionistic approach to how you view a problem. Like humans are not just basic machines where the parts can be separated. We're an integrated system where we've talked a little bit about this sort of that biotensegrity model where you actually have forces not just limited to that particular compartment. It's actually, have you ever heard of that? I think I've explained it to you before, the concept of proximate versus ultimate causes. So like if someone has a soft tissue injury, there's going to be proximate impairments that you find, reductions in strength, reductions in range of movement, reductions in the overall
rate of force development, torque capability, all these different sort of metrics of that specific, the dimensions of the calf itself and that complex.
But then you've got the ultimate causes of like, well, hang on, is there something going on here? Like they've had this previous knee injury. Has that actually caused impairments at their knee or their hip? But then I guess that can always be a bit of a challenge too of then, well, how much searching do you go into? Like how much data do you actually collect and how much can you actually do with all that data? Do you have a particular process that you follow?
Yeah, we do. So in summary, at the very sort of bare bones in terms of assessment, we'd be checking hip extension range of motion, hip extension strength, hip abduction strength.
How do you measure?
Yeah,
Like what actual testing are you doing? What's the the type of test that you do?
We have valve systems at the club that we can utilize, as well as you can do handheld dynamometry. We cover off on those things. If there was a particular pathology or clinical history around the hip, we might do some assessment of rotational strength as well. And then moving down the chain, identifying any impairments in hamstring function or length, rectus femoris or quadricep function or length. And then at the ankle, of course, are there deficits in range of motion that are going to precipitate abnormalities in mechanics and loading that occurs throughout the kinetic chain? So we're kind of looking at the hip, the knee, the ankle and the foot systematically. So nothing too complex or nothing that clinicians around the world wouldn't look at, but I think it's just important to take the time to go through that process because, as John mentioned, this is your opportunity to iron out those kinks.
Talking about kinks, I'm sure some of the older players, particularly, their bodies are battered.
Yeah.
What's the process that you guys go through to work out, okay, that's never going to get to an exceptional level because of whatever pathology is present, and working out, no, we can attack this and this, but we're not going to probably make a huge amount of changes there. Is that an iterative trial and error process, or is it something that you guys actually have a very clear
that's
protocol,
really,
a process by which you make those decisions? I can imagine you have some players who just if you look at their scans, you'd be like, oh my god, this poor bloke's body is destroyed.
There's certainly a challenge, and I think that's where we don't lose sight from the fact that we put most of our energies into the big rocks, ensure that we're covering off on those big rocks as best we can. And then that'll give us better scope to hone in on the intricacies. I think working with these guys on a daily basis, you can have really open conversations, even with them about, we think these are your main priorities. You also have these issues. We're going to cover off on these.
Do you ever think there's an issue? Like, I've had this problem recently, and it's been a big error on my part of, when you have a good relationship with the athlete at a professional level, and if you guys, it would be the players that have been there for 7, 8, 10 years, and you start to make assumptions about, oh, that's not going to change, so we won't touch that. Even though if you came to it, as I say, with a child's mind, and you came to it naive, you say you were the new clinician, you'd be like, that's actually something really important.
Yeah.
It's a mistake I know I've made a lot of times, and I've had to kick myself in the ass and say, no, this athlete can't get away with having terrible ankle range or terrible hip range just because they've always had it and I've let it go. How do you sort of reconcile that with some of these players who, I'm sure the injuries are probably significant, particularly joint pathology and stuff like that. But in your mind, you're thinking, okay, well, are we avoiding this at their detriment because we're actually almost using that label of the pathology or going, oh, that's just them.
That's just what it is. And really good point. And I think that's a luxury of perhaps working in a team environment where, there's 2 other physios within our team. We have 3 S&C coaches. We have 2 doctors. And we devote time to discussing each case. And everybody has the ability to give their perspective, which are varied in terms of people's expertise and knowledge, and also in terms of people's personalities, which I think is important in a team dynamic. So that's perhaps a nice part about working in a team, in that you can lean on others, you can utilize their expertise and perspectives. I've certainly found that helpful in that regard. Yeah.
Can I ask a provocative question?
So given the length of our discussion with Brady Green, we decided to break it up into two parts, this being the end of the first one. We hope you enjoyed it.